Hello, and thank you for joining us for today's episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University. My name is Chris Curry, and I am the Communications and Marketing Manager here at the Georgia Cancer Center. Today, I am joined by Dr. Zach Klaassen. Dr. Klaassen is a urologic oncologist here at the Georgia Cancer Center. And Dr. Klaassen, I want to thank you for spending part of today with us for today's conversation about testicular cancer.
Great, Chris. Always good to chat with you.
So April is Testicular Cancer Awareness Month, and we want to take this time with Dr. Klaassen to educate each of you about this disease, especially discussing why it's important for parents to engage with teenage boys in their household about self-exams.
Yep.
But Dr. Klaassen, before we dive into that topic, I want to talk a little bit more about you, your background, give the listeners some info.
Sure.
So what made you decide to pursue a career in urologic cancer, testicular, prostate, etc.?
Yeah, it's a good question, Chris. I think, early on in my residency, I did my training here from 2011 to 2016. And early on, probably in my second, maybe third year of training, I really, seeing patients in the clinic and, starting to do some operations at that point with the faculty. I think the cancer patients, I always had a good connection with them. And I think part of that's personality, part of that is just enjoying those operations. But I think that sort of fostered over the next couple of years as I moved into my senior years of residency and enjoying the research aspect as well. That kind of goes hand in hand with being a urologic oncologist. So from that point, I did 2 years of oncology fellowship in Toronto at the Princess Margaret Cancer Center. And that was a strategic move because they have the biggest testis cancer program in Canada and one of the top 3 in terms of size in North America. So going to Toronto really sort of continued that development. And obviously, as you mentioned, we treat 5 to 7 malignancies typically, but the testis cancer aspect really sort of was continued to be fostered, and with just great mentors and faculty up there to sort of bring that practice back to the cancer center here.
Why testicular cancer? Why is that such a passion area of yours?
Yeah, I think it's a very unique aspect of oncology in the sense that these are young men, and so they're typically between 16 and 39 years of age. Obviously, there's outside that range as well, but these are young men in the middle of either high school or college or getting on with their first or second job and families, and that's. I mean, I don't want to age myself, but I'm still in that age range barely.
Yeah.
But I think I'm able to connect with those men quite well, and I think they see somebody who could be just like them. And I think being a natural people person and being able to connect with these guys and their families and their girlfriends and wives, I think was easy to do. And I think there's a sort of dogma in the testis cancer world that you have to be fully engaged. I know we're going to talk more about that too, but you have to be fully engaged with these guys, and you have to understand the complexities of the nuances and the treatments and who needs surveillance and who needs treatment, what kind of treatment, and also be their biggest advocate. And I think that whole package to me is why I particularly love treating testis cancer patients.
When you talk about your research, so obviously you're a urologic oncologist, so you see patients, but research is also a passion area of yours. Talk about some of the research topics that you're interested in.
Yeah, I did some clinical epidemiology training while I was in Toronto, and so a lot of epidemiology is sort of non-specific, but it's basically non-specific in the sense that if you ask a good question and you have the right data, you can get the right answer to it. I think any of those types of questions that come up with testis or any other malignancy are sort of in my wheelhouse. So that may be as simple as looking at disparities in treatment care for certain aspects of testicular cancer or prostate cancer. I've also we've talked about this as well, about a mental health and oncology angle that I've been very interested in because of the psychological burden with these diagnoses, particularly in men with testicular cancer. And so we're partnering with some of the testicular cancer societies to look at their group and have surveys and look at what these, straight from the patient source and aspects where we can try to improve our delivery and what we talk about and how we counsel men about this disease. So that's just a little snapshot of what sort of interests me from a research standpoint.
And I know that we have talked about this in a couple of episodes, some that have been published and some that will be published. But talk a little bit about the Georgia Cancer Center's Psychosocial Oncology program. I know that it has been growing and wants to grow more to offer even more services. Talk a little bit about that and how important it is for testicular cancer patients.
Yeah, it's a great service here. Lauren Bingham, who runs the psycho-oncology service, and I know she has a couple of fellows now as well. And so that aspect of the cancer center, I think, is a true hidden gem that we have. And particularly when we're talking about testis cancer and, going from the diagnosis to the treatment to the follow-up to the side effects, I engage Lauren as much as I can, as early as I can, for people that want it. Obviously, not everybody's going to go see her and her team, but I think it's a huge benefit that we offer here, and I think the people that do go, they think it's fantastic because it's not a stigma to go see somebody like this. This is a massive disruption to somebody, a young man's life, and there's obviously going to be all the feelings of coping that people go through when they're diagnosed and undergo treatment. And I think having somebody trained to walk them through that is such a huge benefit. I mean, we do it as surgeons and oncologists, but they're specifically trained to sit down with them and have the right questions to ask. And our job is to get these people to the people that are the experts in it. And I think it's an easy avenue here, which I know most cancer centers have, but I know we're fortunate here with what the setup we have.
Yeah. Let's talk about the parents, because we talked a little bit about that in the intro. Parents play a role in this, and I'm kind of curious what sort of conversations you want parents to have with their teenage boys or even their young adult men, because you talked about 16 kind of being where it starts if it develops, but even into their 20s and 30s, like mom and dad, aunts and uncles can still be sources of mentorship and going to them for advice in certain situations. What do you hope and what do you want parents and confidants or mentors of men to be talking about?
I think it's being aware of what's going on your body, and that sounds a little bit interesting, but it's true. I mean, we talk about self-exam for breast cancer. It's the exact same thing with testicular cancer, and so we advocate for once a month in the shower doing a self-exam. Any lumps or bumps or things that don't feel normal, have somebody have a clinical or have a physician or a provider take a look at it. And it may be as simple as just going to your family doctor. It starts with just an awareness of how these develop. And I think, even and podcasts like this, so people understand. I mean, most people, even other specialties, don't necessarily know that testicular cancer is the age group we talked about. We think of cancer, we think of old people, and this is very different. And I think, I give a talk to the third year medical students a couple times a year, and some of them will come up to me after and say, I didn't realize it was this age group. So I think, and everybody in that room is in that 16 to 39 age group. So I think it's education, just like most things are, and it's early detection. And to answer your question about the parents, I think, 16 is a tough age to be a male.
Yes.
And I think there may not be that ability to have the conversation, but I think just mentioning it in a lighthearted way and being aware and not being afraid to say something.
Yeah.
The majority of people that come in with advanced testicular masses are just scared because they're embarrassed. It's abnormal. It's unusual, and we'll deal with that later kind of thing. And also, it's a few months down the road. So I think the early detection goes alongside with the education and the self-examinations.
Yeah. So you were a resident here and started to sort of develop a passion for urologic cancer and testicular cancer and such.
Yeah.
But, what do you talk to your residents about? Because they are going to be younger.
Sure.
And what do you talk to them about when it comes to interacting with testicular cancer patients? And
yeah, I think it's a great question. I think it sort of sums up how we should be with as physicians to all of our patients, but particularly this vulnerable age group and demographic. And I think you have to be your patient, and I'll say patient because I think it's not just testicular cancer, it's everybody that we see, but
Yeah.
you have to be your patient's biggest advocate.
And what do you mean by that?
So I had a mentor when I was a med student and I was interested in general surgery at that time. He said, if as an oncologist, if I ever give up hope, the patient gives up hope. That doesn't mean you're not honest with them and you don't tell them this is what we have to do and the prognosis is this and we have to work through this to get to this. But it's not giving up hope. It's being honest and it's holding their hand, but it's being their biggest cheerleader and their advocate. Because if you're not that, then what do they have? What are they holding on to?
Yeah.
And also engaging the families. I think the family aspect is absolutely crucial, not just with testicular cancer patients for sure, but all patients that we see. And I think the if we look at a clinic that I see on Monday, whether it's 50 or 60 patients, it's a lot of cheerleading, and that's part of your job.
Yeah.
And I think having the residents that you train and they're going to go off and they're going to have their practices in a couple of years, and if they can take a piece of that to their practice, and they may not all be oncologists, but you're going to see cancer patients in a urology practice no matter where you are. I think that's the biggest aspect is that being their advocate, being their cheerleader, and being their source of hope for whether it be the next day, the next week, the next month. So,
what made you come back? Because you said you did your residency here. What made you come back to Augusta University Health and the Georgia Cancer Center?
Yeah, it's funny because as being from Canada, when I first, in Western Canada, when I first matched here, I thought about coming to Georgia in 2011. As somebody who's 24, 25 at that age, I've never been to Georgia, and I'd never been.
Had you ever been out of Canada?
I've been out of Canada to Mexico a few times, but I hadn't been to the Southeast. And
okay.
And I remember telling my wife that when I interviewed here, I said, I think this is the place we're going to be, and it was. And so 5 years, 5 years of residency. But even before that 5 years was up, we had a conversation probably three and a half years in. That this would be a place we'd like to come back to and be here for a while. And so those conversations led to talking to, the people that do the hiring and that kind of thing. And things moved very easily. And, we went to Toronto and we had sort of a handshake agreement to come back and we couldn't wait to get back. And I think to answer your question, the reason we wanted to come back is this is a great community. It's a great place to raise a family. It's the patient population here is a great population to take care of. They're very appreciative. They're very grateful. And not that you have to be all those things, but this is just a Southern sort of way of doing things. And I think as a oncologist and a surgeon, it's fun taking care of those people. They're easy to take care of. And I think I love this program. I love the MCG urology program, and certainly being now at the Cancer Center for 3.5 years, I love the Cancer Center. And so when you put all those things together, the quality of life and your family's happy, and you've got job satisfaction, you're making a difference hopefully in people's lives as both patients and residents and training and mentoring. It was a very easy decision to come back that we haven't looked back from at all.
Well, that's awesome. Well, we're glad that you're here. We're glad to have you. I enjoy working with you and talking to you. How common is testicular cancer here in Georgia and our neighbor, South Carolina?
Yeah, so testis cancer, it's not prostate or breast or lung. It's not that common. We, as a tertiary center and as sort of what we're building here is a sort of testicular cancer, center of excellence for the state of Georgia. It's not common, but we do see a lot of it because it gets referred in. So to answer your question, in Georgia, there's going to be about 225 new cases this year in the state.
Okay.
To give you an idea what the denominator is, there's going to be about 58,000 new cancer cases altogether.
Okay.
So it gives an idea what that percentage is. In South Carolina, it's a little bit less. So there'll be about 34,000 new cases of cancer in South Carolina in 2022.
Okay.
And about 140 to 150 of those will be in testicular cancer.
Okay. Is there any difference between different races and ethnicities when it comes to testicular cancer? I know we've we've done stories here at the Cancer Center,
Yeah.
shared information on social media about some of the disparities in other kinds of cancer. Do you see that in testicular cancer as well?
Yeah, for whatever reason, and we don't have a great answer for it. It's historically, and we see it here as well. It's a Caucasian malignancy. We do see it in Hispanic men as well, and Indian men, but majority is Caucasian men. Very rarely in African American men.
Wow.
Which is much different than a lot of other
Yeah.
cancers like prostate and I'm sure breast as well. So
Yeah.
you don't find much testicular cancer in Africa, for example. It's a very much Scandinavian sort of European
Okay.
cancer that we see.
And I know that at the Cancer Center at Augusta University Health, we have a team, a physician liaison team that helps to introduce y'all, connect y'all with different referring physicians across Georgia and some of South Carolina.
Yeah.
What sort of conversations do you have? Do you kind of give them tips or strategies when it comes to testicular cancer? Because, primary care providers probably necessarily don't have the
Sure.
level of expertise with that specific disease, but they may have men that come in. You talked about going to a
Yep.
primary care provider just to get a lump or a bump checked out.
Yeah, absolutely. And I think that's a great point. I mean, there's going to be like 220 in Georgia this year, 140 in South Carolina. So, you may see one or two as a primary care provider per year, if that, right?
Mm-hmm.
So when we go to the community, I actually just had a good friend and referral source from Aiken call me this last week about a 26-year-old guy that he was going to see on Wednesday. He was going to confirm, and then I said, "Yep, just shoot me a text or call me when you confirm." And he did, and I said, the first thing I tell them is if you're worried about anything down there, just send it over.
Yeah.
It's so easy to have a 10, 15-minute visit with a young guy and say, "You're fine."
Yeah.
So it's great for the patient. It's great for the physician that sent them over. And if there is something that needs to be addressed, these are the patients. We try to get people in as fast as we can.
Yeah.
Certainly the testicular cancer potentials or confirmed diagnosis, we'll see them within a couple of days, if not a week at most. So, for instance, going back to this example, this young man's coming to see me this coming Monday, and we'll get him expedited to what he needs to have done. So,
what's it like for you and your residents walking into a room where a guy, a 21-year-old guy,
Yeah.
comes to you for the first visit for testicular cancer? What is that like for them and for you?
it's probably scary for them. I mean, a lot of I kind of remember when I was 21, and you're invincible until you're not.
Yeah.
So I think first of all, it's fear, even though they may not show it. I know they're scared because I could imagine what that would be like when I was 21 or 22 years old.
Yeah.
Sometimes it's anger. Usually the anger comes later, but it's usually just fear in the first part. And for us, when we walk in, I always tell the residents within 5 seconds you should be able to understand the temperature of the room, whether you can see how people are doing, how they look, how they're acting, their body language, how their family members may be, whether it's nervous, anger, scared, sick, especially in some post-op patients. So you have to get a temperature very quickly, and you kind of know going in what it probably will be, but you have to have an ability to get the temperature of the room and then sort of take the conversation from there. So from our standpoint, we have a game plan, and I sort of have a built-in sort of sequence of how we're going to address things and talk about things, and sometimes you have to switch that up depending on how they're reacting or how they're interacting with you, and I think the majority of the people that when you see them for that first time, they want to know things like what's next. Mm-hmm. They want to have a plan. It may have taken a lot just to get them to that appointment.
Yeah.
Not physically, but I mean, like from a mental standpoint, to say, okay, I need to go see the cancer doctor.
Yeah.
And that's a scary thing.
Yeah.
So I always thank them for coming to see me. I think that sort of takes it's like a bit of an icebreaker because I'm glad they came to see me.
Yeah. Yeah.
And I think you can almost see them relax a little bit, and then we start to talk about, this is what you have. I usually print off a picture of the ultrasound, obviously do a physical exam, and then we go through what the next steps will be. and they always get my card with my email and my cell phone. And I think it's important for these men to have access to people that are available, and what better available than your oncologist. I think it's really important that and I think that helps with follow-up, because a lot of the follow-up for testis cancer is very strenuous in terms of frequency of visits for various reasons, and I think, that keeps them engaged, and we need them engaged.
Do you get a lot of late night, overnight phone calls, text messages?
Not really. Every once in a while, but not really.
Okay.
I think most folks are great. I mean, it's emails for the most part. I'll say, like, if it's urgent, call me.
Yeah.
If it's just a question, just shoot me an email, because I'll get back to you within 24 to 40 hours typically.
One of the things that we always talk about here at the Cancer Center is every single patient, every single case, every single cancer is unique and individual to that person. But what does sort of the general plan look like? What sort of treatment options are there? Chemotherapy, surgery, radiation? How does all that play in?
So the typical patient would, they come in with a testicular mass. So the first step is to confirm that, whether it's physical exam or review imaging. Once that's confirmed, 99% of the time, the first step in management is an orchiectomy, so removal of the testicle. Okay. And that's typically a 30 to 40-minute surgery. It's same day. People typically recover quickly. It's an incision, maybe this, depending how big the test mass is, usually a few inches on the groin. Okay. And once that they have that operation done, we send that testicle off to the pathologist. Before they actually get to the ER, I'll back up a little bit, they get sort of routine labs that will tell us there's certain tumor markers that we look for with testicular cancer. So we get those before the orchiectomy. And then once the pathology's back, we have tumor markers. We've gotten a CT scan of the chest, abdomen, pelvis, make sure it hasn't spread. So once we have all that information, we then embark on a pathway of either surveillance. So if it hasn't spread to the lymph nodes in the abdomen or to the chest, we do surveillance, which is a series of tumor marker testing and CT imaging over the course of 5 to 7 years.
How often?
The first couple of years, it's every couple of months. Okay. So they're either getting tumor markers or they're getting CTs every couple of months. So it's pretty rigorous.
Pretty aggressive to make sure that
it's not coming
spreading.
Back. And so if there is lymph nodes involved, and usually the lymph nodes are in sort of along the big vessels that come and go from the heart. Okay. And then at that point they'll do chemotherapy, and that's usually 4 cycles of chemotherapy, and this is high dose chemo. One of the reasons the success rate and the survivability of testicular cancer is gotten remarkably better than it was in the 70s and 80s is the chemotherapy dose you can give young men is very high. If we give this to 70 and 80-year-old people, they wouldn't be able to tolerate it. Yeah. So we're able to really attack the tumor with a high dose of chemotherapy. Based off of that may be all the treatment they need at that point. In some men, they'll have a great reduction in the size of their masses in the abdomen, and occasionally we will do surgery to remove those masses, and that's a big operation. That's called the retroperitoneal lymph node dissection. Okay. And so I typically do between 8 and 12 of those a year. Okay. And it's anywhere from a 4 to a 6 to my longest is 16-hour operation. Wow. Depending how much of disease is left. And so often at times, because we're working around the big vessels, I'll work with my vascular surgeons and sometimes surgical oncologist, Dr. Cruz, Dr. Rohr, that team. So there's a lot of different pathways things go based on how you sort of present, whether it's just localized with no spread, some spread but get a good response to chemo, spread with chemo and some residual that we have to go operate on. So I hope that answers. It's kind of a long-winded question to sort of a complex sort of. But there's several avenues. Not everybody gets a big operation where we go take all the lymph nodes. Right. So I think that, and I'll sort of dovetail off of the follow-up you mentioned. One thing we've done, and I've sort of adopted it from my colleagues in Toronto when I was there. We've got phenomenal algorithms for what their follow-up will be. Okay. And it's a PDF. It's literally a calendar. Okay. So if you come in with what's called non-seminomatous germ cell tumor, it's in the testicle but hasn't spread anywhere else, your tumor markers all come back down, you're a perfect candidate for surveillance. That next visit, I will give you a PDF of the next literally 7 years of the appointments, which I think really helps with engagement and keeping
Because then they know.
Then they know. They're like, I'm going to see Zach in 2 months, 4 months, 6 months, 8 months.
They
Then
put it on their
I get a little
calendars.
break from him, and we'll go to 4 months, and then we'll go to 6 months, then it'll be 6 months again, and annual. So, I really love having that because people can, it's good for the residents for teaching because they know they know about the calendars.
Yeah.
And so they're like, well, when do you want to see him back? I'm like, pull up the calendar, tell me how far out they are from their operation.
Yeah.
And the patients love it because they literally put it on their fridge and they know they
Yeah.
can say, all right, June, August, and it's very sort of regimented, and so it's frequent visits, but it's a lot of this is you want to distill as much of the unknown as you can.
Yeah.
So I think that helps a lot.
So obviously we're talking about the testicles, which is, part of the reproductive system. What sort of conversations are you having with men about fertility, especially if they're on the younger side, they don't have kids, but maybe they want kids, aren't sure they want kids yet?
Yep.
What's that conversation
It's a
like?
great question. So the first part of that answer, I think, is if you have a testis mass, the other testis is normal, and you're not getting any other radiation or chemo or surgery, oftentimes, and I'll offer it to everybody, but oftentimes there's nothing else to do. You're going to be fine. You have a fully functional testicle that will produce necessary sperm to procreate when you'd like to. And the conversation when it's more advanced, and we're going to for sure do chemo, and we're going to potentially do, surgery, is sperm banking at that point, because certainly the doses of chemo, not everybody becomes infertile after chemo, but there certainly is a proportion of men that will be. And I think the sperm banking is an important conversation before anything's done, so that that process can get going, and they can get sperm bank before they undergo the chemo or the surgery.
Yeah. Just to bring this all sort of back, one of the keys here really is that early detection, because
For sure.
it sounds like the earlier you find it, it's easier to treat,
No
and
doubt.
they have a better opportunity or ability to potentially be on that surveillance program.
For sure. I mean, I think early detection for any malignancy is key, and especially for the ones that we deal with. But if we're talking testicular cancer, for sure, if the most you need, and I don't say that lightly, but if the most you need is an orchiectomy and nothing else, we partner with some industry companies that have basically fake testicles that we can put in if you want one.
Oh, wow.
So from a cosmetic standpoint, let's
Okay.
say you're 19 years old, or say you're 16 years old, you're a junior in high school,
Yeah.
and you need an orchiectomy for testis cancer, and you're kind of looking down below and you see one on one side, it's kind of empty, the scrotum doesn't look normal.
Yeah.
We can do a 30-minute operation either at the same time or down the road, and it's literally called a nudicle, without being funny.
Okay.
It goes in the scrotum and it feels like one, and
Okay.
it's really kind of a neat. It's called a prosthesis because it's fake.
Yeah.
But it's great for we call it the locker room appearance. They look and they feel normal.
Yeah.
And I think that's important, especially for the younger men. I mean, I think once you get into your 30s and late 30s, I don't think necessarily but some people do. But particularly for the guys in high school and college, I think that's nice to offer that as well.
Which is really nice, because obviously we're talking about testicular cancer, but when it comes to breast cancer, our Image Boutique in Sherry Brooks, they do offer prostheses for breast for women.
Sure.
So that, if they have one or both
That's right.
removed for their treatment, so it just helps them feel more normal.
It's exactly right. I mean, it's a huge part of these young men getting on with the rest of their life. And if they look and they feel normal like they did before the diagnosis, anything we can do to help that. And I love putting these in because I think it's a great service.
Yeah.
And I think anything to help them continue to move on past the diagnosis and what the stigma of that means and what they've had to go through, I think is awesome.
Well, Dr. Klaassen, this has been very informative, very educational. I thank you very much for taking the time to have today's conversation with me about testicular cancer. And if you people out there, men, women, moms, dads, aunts, uncles, if you have questions, we publish these on YouTube. They are on Apple Podcasts, Google Podcasts, Spotify's podcast program. please submit the questions. Email us, cancer@augusta.edu. We want to help y'all feel better and feel more educated and feel more prepared to talk about this topic.
Chris, it's always a pleasure. I think, every time April comes around, I think this is, and we should be, I think, doing this more often if we can. Obviously, it's Testicular Cancer Awareness Month, but certainly this opportunity to come chat is always a good time, and I think it's an important avenue that we have at the Cancer Center.
Well, I appreciate you for coming, and I appreciate you all for watching or listening, and please hit that subscribe button on your podcast program service of choice, and we'll see you next time.